Well, greetings, everybody. I'm Daniel Neely, pediatric ophthalmologist and consultant to CyberSight. It's a lovely rainy day here at the CyberSight studios in Indianapolis, but I appreciate you joining us. Today, we're going to go through strabismus questions and answers. I have a list of questions that have been previously submitted that we will use as the basis here at the beginning. But I also invite you to submit questions live via the chat function. And as those come in, I'll review those and intermix those with the questions that have been previously submitted. For starters here, let me kick off into the PowerPoint. One thing I'd like to point out is that a lot of these questions that we're discussing today are really excellent questions, and a lot of these are kind of like intermediate to advanced level. And I want to remind everybody that we do have strabismus courses available on CyberSight. If you go to the log in to CyberSight, and then once you go to your homepage, as you can see down here where it says catalog, so this will be a listing of all the courses that are available, and here in particular, you'll find the pediatric related topics. Once you start courses, then that you're registered for, then they'll appear over here where it says My Courses, and so it's a nice entry portal here. Once you then enter, once you go into the catalog, you'll see you can search by pediatric ophthalmology. In this case, we have the nursing, neuro-ophthalmology, glaucoma, cataract, soon diabetic retinopathy. But once you go into that pediatric ophthalmology section, you'll see a listing of the courses available related to pediatric ophthalmology. And the one I want to point out to you is this one in the blue where it says Fundamentals of Pediatric Ophthalmology and Strabismus Full Course. Now, this is not just strabismus. Once you launch that, you can see that there are a lot of modules there. There are about 6 modules total. And some of the ones that are going to pertain to our discussion today would be this, the basic evaluation, module 1, but then more importantly, module 2, basic strabismus. This is going to be horizontal muscles, A and B patterns, those kinds of things. And then down here, module 4, which is advanced strabismus. And this is where you get into things like Duane syndrome, superior oblique palsies, and some of these other topics that you've submitted. So I do urge you to take advantage of that resource, which you can do at your convenience. I'd also like to remind everyone that this will be recorded today and will be available on CyberSight under the Library Resources tab. There were a lot of great questions submitted, and I've kind of lumped them together. And here you can see that we had 3 different people asking something similar about the age of strabismus surgery. So best age for strabismus surgery, what is the recommended age for correction of strabismus in children born with it and why? And then related, how do you manage a patient with congenital constant exotropia? All right, so let's kind of lump the first 2 together here first. It's a great question because it's something that people have been looking at for a long time. And I think that, yes, there are some advantages to the timing of the surgery, but ultimately it's going to depend on probably some more local factors because this is not going to be earth-shattering like pediatric cataracts, where you have to have that child have surgery and be optically corrected by 6 to 8 weeks of age, or the outcome is not good. But we have a lot more leeway, and the results are a lot softer when it comes to strabismus. So you have to take into account anesthesia abilities. You know, you don't want to be taking kids too early if it's not safe in your facility. You want to take into account being able to measure the strabismus accurately and not just totally ballparking it. And then you want to see what that's doing over time, and you want to be able to treat amblyopia. So there are a number of factors here, and it's not going to be just an absolute answer. But there are a couple really kind of hallmark studies that I'd like to point out. Probably one of the, when you talk about congenital esotropia, which is where we're talking about timing with congenital strabismus most frequently, this article by Malcolm Ng back in the 80s looked at 154 patients who were managed by pediatric ophthalmologists in several countries, and looked at their outcomes over time. And you know, what they found was that there was not a lot of difference whether you had these children aligned by 6 months versus 12 months versus 24 months. Okay, so this last sentence here, the results of sensory testing showed that those adequately aligned by the age of 6 months versus 12 months versus 24 months were not statistically different. All right, so whether you had them had a perfect surgery at 6 months or you had a perfect surgery at 18 months, it didn't make any difference, and at least in terms of their sensory outcome. All right, now where they did find some drop off was after 24 months. So after 2 years of age, they did start to have a significantly lower percentage with evidence for binocularity. It doesn't mean they had bad outcomes, but in terms of high grade or some grade of stereopsis, they didn't do as well. So, you know, if you had to say, okay, what should my target be when I have a child born with esotropia or exotropia? We'll extrapolate this a little bit. And I would say that having that surgery completed by age 2 years is pretty reasonable. That gives you enough time to see them more than once, get accurate measurements, make sure it's not changing, make sure you've treated any amblyopia. And from an anesthesia standpoint, most facilities can handle children in this age group between 1 and 2 years of age. So I think that's a pretty good target. Now, there historically has at times been a push for ultra early surgery. And as a matter of fact, when I was a fellow 20 some years ago, I looked at this with my mentor, Dr. Helvison, and I had the job of going out and examining people in their homes 10 to 20 years after their surgery. And these patients, it was a group of just 10 patients, but they had all had surgery at about 4 months of age for congenital esotropia. And basically we found that there was no amazing outcome. They still required a couple surgeries on average. They all had good alignments, less than 10 prism diopters of esotropia. But in terms of the sensory outcomes, still 9 of 10 had DVD, 4 of 10 had latent nystagmus, and 4 did have measurable stereoacuity, but we're talking about generally usually 3,000 arc seconds or the fly. A couple were better than that. One had 400 seconds and one had 140 seconds. So really you're just looking at the possibility that early alignment gives better stereopsis. But I don't think that that's earth-shattering enough to kind of force early surgery on these kids. Now, relative to the exotropia question, how do I manage children with exotropia? Pretty much the same way I do with esotropia, congenital. First thing I do is try and get some estimate of the angle, of course. And if there's a fixation preference, I may do some patching. If you're seeing these children really young, say they're 4 months, 3 months, I usually will see them a couple months later and repeat their measurements. And as soon as I feel that they have relatively equal vision with the amblyopia treatment if needed, and as soon as I feel that the measurements are stable and that I'm relatively confident in the amount that I'm anticipating to do surgery for, then for me that's the time to do surgery. So it's more along those lines than it is saying, okay, I'm going to do surgery at 6 months or I'm going to do surgery at 12 months. I think you have to be adaptable and base your target on those other factors. In my institution, the anesthesia is not a concern, but if it is in your institution, then I think that's probably the biggest factor. Because the advantages of early surgery are so soft, the last thing you want to do is do an unsafe surgery if you have anesthesia concerns. Okay, so I think that's where I would leave that. Next question. This is always a good question. In cases of consecutive strabismus, what is the best management plan? Well, okay, so what's the most common situation here? The most common situation is that you do surgery for esotropia and they are either slightly exotropic right away or they become exotropic over time. All right, so how do you decide? In terms of a corrective surgery, for me, it really depends on what their motility looks like. I'm gonna go to the whiteboard here. All right, so here it comes. All right, so if I'm seeing someone in follow-up, oops, well, I don't really want to listen to music or the Lion King here, so let's close that down. Okay, so if I'm seeing someone in follow-up and they had a BMR of 6 for congenital ET, and then they come back post-operatively, and now a few months or a few years later, they now have XT 15. All right. Well, what are we going to do? Well, let's look at their motility. So motility grid, again, 2 ways you can look at motility. I use these H's. Other people use asterisk kind of shape, right? All right, so if you look at their motility and they've had their medial rectus recessed 6, you want to know, is their adduction full? This is what we're interested in. What is their adduction? All right. If I see someone and they can't bury the sclera, they have -1 adduction, then for me it becomes a very simple. All right, so that's the same as this, right? These 2 methods. For me, that tells me if I'm going to fix this, I need to go back and look at those medial rectus muscles, and I need to figure out, why is this happening? Because they're probably slipped. They're definitely overcorrected. They shouldn't be crippled if they only had 6 millimeter recession. So their motility should be full. So that suggests to me I need to go back and look at these and advance them. And if there's an area of empty scar tissue, then I need to resect that. All right. Now, people don't like doing that because it's a little bit harder to plan, well, how much am I going to do? But that's the only way you're going to fix these people. However, what if this is not the case? All right. What if they have this consecutive 15 XT, but you look at their motility and it's normal, okay? So we say it's full, their motility is full. Well, now what do I do? Now I can do whatever I want. So why would I want to do something difficult like advancing medial rectus muscles if the motility is full? If the motility is full, I'll simply do a lateral rectus recession on one or both sides for 15 prison diopters. I will treat them just like I would treat someone who had never had surgery before. All right, that's my approach to it. Now, there's another situation here. Erase this. You have people that, let's say they were ET, all right? So they started off ET and they have a BMR, but they're still ET. So now they have a second surgery. Second surgery, they're going to have bilateral lateral rectus resection or plication. And then this is when they become XT. So they've had 2 surgeries for ET and now they're XT. All right, what do we think is the culprit here? Do I think that they have slipped medial rectus muscles? No. So because the most recent surgery was this one, the lateral rectus resections, unless even if the motility might be a little bit limited, I might just assume that this is too tight. Okay, so if they went XT after the resections, this is where I'm going to focus my attention. And I'm going to go back and I'm going to explore the laterals. And I'm going to recess them. All right, so that's how I'm going to deal with the consecutive strabismus in this particular case. All right, so motility and presence of motility deficits is your #1 guiding force. And you'll see this a lot of times, particularly you'll see this in adult patients. So they had surgery as a child, and then they come back a few years or a few decades later, and now they're exotropic. And very frequently you see people that had surgery as a child have these consecutive exodeviations. All right, let me look at the live questions, see what we have here. All right, here's a question related to the first topic we were talking about regarding congenital exotropia. Would you suggest a neurologic exam, brain imaging, or any further systemic investigation other than ophthalmic concerns? Yeah, that's a good question, because this has come up because congenital exotropia is less common. There at times have been suggestions that these children are more likely to have neurologic impairments, and that you should do maybe more of a workup than you would for a child with congenital esotropia. And I don't do that. I think that the reports on that are mixed. There are reports that say that there's no higher incidence of neurologic abnormalities. But of course, with both of these, you can see children with and without neurologic abnormalities, whether it's congenital ET or congenital XT. All right. But keep in mind that the true definition of congenital esotropia is that that's their only problem. They don't have any other neurologic issues. And so I think by default, the true definition of congenital exotropia is going to be the same thing. If you have infantile exotropia and that's your diagnosis, they should have no other neurologic issues. Anytime you see these kids, whether it's ET or XT as infants, as long as they seem neurologically normal and their growth and development are normal, and there don't seem to be any other concerns from a physical or neurologic standpoint, I don't automatically do neuroimaging. I don't think it's necessary. Okay, so I think you have to take all of these as a case-by-case basis. It's just like when you see say you see a 5-year-old with an acquired ET that's non-refractive. I don't automatically image all those kids. I think you have to look at them, talk to them, and see if there's anything else that's a red flag that makes you want to put them through an MRI or a CT scan or some other expensive evaluation. All right. We'll touch on this one too. Second question, nystagmus with strabismus. Question is, just correct the strabismus or not? So when you see nystagmus with strabismus, there can be, I don't think there's going to be a straightforward answer here, because it can be a host of things. Kids with congenital esotropia usually have latent nystagmus, and they may have manifest latent nystagmus. Well, in these children, we're not doing anything other than just treating their esotropia. Now, that's going to be different from someone who has maybe albinism or optic nerve hypoplasia, and they've got nystagmus and sensory strabismus. In those cases, you may choose to combine the two surgeries. So say someone has, let's go with albinism, let's say they have an exotropia and nystagmus. And you're going to fix the nystagmus by doing lateral rectus recessions. Well, maybe you want to also try to dampen their nystagmus by doing 4 muscle recessions or tenotomy without recession of the medial rectus muscles. And then, of course, all of this gets even more complicated when you start talking about people that have head postures, and you're doing a Kestenbaum-Anderson to improve their head posture, but they also have strabismus. And then you have to start looking at the tables and deciding how much you're going to change the amounts of recession or resection to accomplish both goals. You want to straighten the head turn, but you also want to correct their strabismus. And that gets to be, again, there's no formula for that, but you need to start looking at the numbers and shaving off or adding appropriate amounts to compensate for the strabismus as well as the head turn. All right, I'm going to go back to the previously submitted questions here. All right, and get some of these windows out of my way. All right, so that was the consecutive role of Botox in strabismus management. That's a good question. And again, you're going to find a lot of individual and regional variability to this answer. In the UK, John Lee, who passed away a few years ago, he was really a big Botox user. And he would use Botox for congenital esotropia and other acquired esotropias by the thousands. And that was his go-to. I think that was kind of unique. I don't think most people do that, but he was quite happy with his results doing that. I would say that for me personally and the people that I work with, we mostly use Botox in the setting of say, acquired sixth nerve palsy. That's definitely going to be the most common thing. So you see someone who has an acquired sixth nerve palsy, right? And let's say they're about 6 weeks out from their onset of their palsy. All right, so what's that look like? You have someone who has a new sixth nerve palsy, and as a result, they've got this ET of 40, and this has been there for 6 weeks. All right, well, they have such limited motility here. What we don't want to have happen is we don't want this medial rectus, this antagonist, we don't want this antagonist medial rectus muscle to contract, right? We want it to stay loose so that it's not interfering with later correction as hopefully this recovers, or as you decide to do surgery for this. So in these cases, in acute sixth nerve palsy, I will do Botox to the medial rectus. All right, whether you do that in the office or whether you do that in the operating room, I think doesn't matter. That's going to just be personal preference. I personally like to take people to the operating room and give them a little bit of propofol, and then I'll use a fixation forceps, and I'll abduct the eye to get my needle started, and then I'll pull the eye back into the primary position and try and put my needle as close as I can to the medial rectus before I inject. And I'll put about 5 units, right? So I'll put about 5 units of Botox into the vicinity of the medial rectus, and then generally try to have them elevated the head of the bed, or have them sit up so that you don't get too much spread of the Botox superiorly towards the levator. I think that does help. The other use for it sometimes is chronic palsies. A lot of times, so this, I think the best use is what we just discussed here, these acute palsies. But what if it was 6 months ago? And now you're seeing them and they didn't recover, and they've got this total sixth nerve palsy, and they've got that same kind of 45 ET. All right, so someone like that's going to need a full tendon transposition, right? They've got no lateral rectus function at all. So I like to take the superior and inferior rectus muscles, and I like to transpose those temporal. And you can do that with a Foster augmentation suture, or you can do it by itself. but it's nice if you can relax this medial again first. So ideally, you would do Botox to that medial a few weeks before you do the surgery, and try and get that medial to loosen up. Now, we don't always have that luxury, and I'll admit most of the time I don't end up doing that. I either do it at the time of surgery or I don't do it at all. But that would be the other big use. Okay, so that's my prime use for it, which is these 6 nerve palsies. When else do I use it? Oh, I've had some kids with infantile esotropia or acquired non-refractive esotropias, and I thought maybe they're going to recover. All right, or maybe their neurologic status is questionable enough that we think that they're going to improve, or maybe this is a post-viral thing. You know, there are a host of scenarios where you're not sure that you should intervene surgically with something semi-permanent, reversible but semi-permanent, and in those cases I will sometimes use Botox rather than surgical adjustment of the muscles, and I've had relatively good luck with that. Now, do I think it keeps you from doing surgery? I think in most of those cases I've ended up still needing to do their surgery, do their medial rectus recessions, but that's the other time where I will sometimes just kind of buy time. And there certainly are enough reports in infantile cases of people having good results by just simply getting good sensory fusion early on that I think it's not out of the question. But again, I think for most of us, it boils down to the cost. Botox is about $400 a vial, $400 US a vial, and you're only going to probably be able to use it on one patient because you're not going to have a bunch of kids running around with esotropia that you can use it on. So expense is another one. All right. And let me go to the live questions here. How about the recurrence rate after correction of sensory strabismus? How much effective control can be seen when prescription over minus an intermittent exotropia? Okay, well, those are really 2 different questions. I'll come back to that one because I think we have one of those previously submitted, but let's just briefly chat about the recurrence rate after sensory exotropia. Yeah, the recurrence rate is higher because that's why they developed the sensory exotropia to begin with. But I don't think that doesn't keep you from doing the surgery. That just means that you explain it to the patient that, for me, most people when I talk to about strabismus surgery, I say, look, you got about an 80% chance, regardless of what surgery you're doing, that you can have one surgery and you're probably done. You have about a 20% chance you're going to be undercorrected or overcorrected, or it's going to change over time and you're going to need a touch-up. All right, and I think those are reasonable numbers for straightforward strabismus. If someone has sensory strabismus or some complicated situation where you're not sure they can maintain their long-term alignment, you just simply say, look, you only have a 70% chance you're going to maintain this. You have a 30% chance you're going to need another surgery. Then they don't care. They just want their eye straight and for it to look good. And if that needs a touch up down the road, they're perfectly fine with that. So you just need to counsel people appropriately. All right, let's go back to the previously submitted questions. All right, this is an interesting one. What's the ideal way of managing small angle esotropia, or let's just say small angle strabismus in general? And the example here is 16 prism diopters of non-refractive, non-accommodative esotropia. This situation, I think, is pretty easy. For me, 16 prism diopters is a single muscle recession. All right. So if you look at surgery tables for 16 of ET, you can probably do something like bilateral medial rectus recessions of 3 or 3.5 millimeters. Or you can do one medial rectus recession of 6.5 millimeters. Okay. Now, some people don't like doing single muscle large recession because they are worried about incompetence or crippling the muscle. But as long as you stay within somewhat of our normal physiologic recession and resection ranges, you're not going to cripple the muscle. So I'm perfectly comfortable doing a single muscle for 14, 15, 16 prism diopters of esotropia. All right. The ones that I think are tough are, what do you do? What do you do when you have something even less than that? You know, what do you do if you have 7, 8, 9? Those are tough because you can't do smaller amounts of recession. So iTunes is just killing me here. Okay. Let's just say we have a patient and they've got 9 ET, or, you know, they've got, so maybe, or they've got, say, 5 of a left hypo, right? So hypotropia. All right, so these are 2 different patients, right? So this one needs a medial rectus recession, and this one would need an inferior rectus recession. Well, what do you do for these kind of numbers? 5, 9? I've only done this a few times, but Ken Wright and perhaps others have described what's called a mini tenotomy. What's that look like? Well, if this is your muscle and you just snip the middle part. Okay, so you take your scissors and you're just cutting right there. All right, so you're leaving the corners up, but now you've created kind of a sag to the muscle here. All right, and he even describes doing this in the office under topical anesthesia. Times I've done it in the operating theater. So a mini tenotomy like that, maybe that can give you 3, 4, 5, something like that. So if you have really small angle strabismus and someone who can't wear prism or won't wear prism because they don't wear glasses, that's an option. I just would have some realistic guarded expectations with that. But by all means, you know, if you have someone who's got 14, 15, 16, whether it's ET or XT, you can do recessions or resections for these smaller amounts quite fine. There was a question about over minus for intermittent exotropia. Let's do that one. Let me find that in our list here. So over minusing for exotropia. Here we go. It's the next question anyway, so that's perfect. So the question was, what about over minusing for exotropia? These other questions are related. Intermittent exotropia, when do you decide to do surgery? What non-surgical management do you recommend if amblyopia is not present? Other question, what are your considerations before operating on a child with intermittent exotropia? Okay, all right, so let's just talk about intermittent exotropia in general. All right, so you see a new patient with intermittent exotropia. What you're going to do probably depends on a few factors. It's going to depend on their age. If you have a 1-year-old or a 2-year-old with intermittent exotropia and they only see it when they're tired, you don't do anything. However, if it's a 30-year-old and they have intermittent exotropia that's happening while they're trying to talk to people at work, and they're really struggling from this with being self-conscious about it, it's not hurting them, obviously. They might have a little bit of transient diplopia or awareness of the deviation, but you're going to be way more quick to offer surgery to that 30-year-old than you are to the 1-year-old or 2-year-old that have the same problem with intermittent exotropia. When I see a 1-year-old or a 2-year-old with intermittent exotropia, as long as they can pull it back in and it's present less than half the time, I just see them every 6 months until they get a little bit older. And I try to save these corrections for this kind of preschool age as you get between 3, 4, 5. When you start, as long as people maintain their near control, this kind of arm's length conversations, as long as they can keep it straight there, they're safe. They are not going to lose stereopsis. So what's the worst thing you can say about their strabismus? It looks funny. Maybe their depth perception's off when it drifts, but they're generally not too troubled by it other than things like light sensitivity or squinting, all right? So you can really be really conservative about when you correct this or if you correct it. Some people don't even want it corrected. But if people start to lose their near control, that's usually definitely a trigger for me, especially when you're talking about children who are school age and sensitive to losing stereopsis. We don't want people to get where they're exotropic all the time. We know that if people have manifest exotropia, the longer they go with that manifest exotropia, probably the less likely they are to have normal stereopsis when you realign them, even if they have a perfect outcome. So we want to not get to that point, but there's a lot of leeway between when it starts and when you decide to do surgery. If you have amblyopia, which you usually don't, right? Intermittent exotropia, they usually don't have amblyopia, but if they do, you would of course treat that. If they have a refractive error, which is interfering with their vision, we of course treat that. So particularly myopes, if someone's a -150, -2 myope, they're blurred and they're going to be more likely to manifest their strabismus. Now, if someone's a hyperope, I just want to point out, you don't want to be giving them their full plus because you want to reduce their plus for sure. You want to take at least a couple diopters off their refraction, at least for children, because you don't want to relax them and have them go out. I mean, that's what we do with esotropes. We try to relax them so that they uncross. If you have an exotrope that you relax, they're going to be more exotropic. All right. Now, what about over-minusing? I'm not a huge fan of over-minusing. I will do it temporarily, but it's just that. It's a temporary kind of thing. What are we talking about? We talk about over-minus. All right, let's just do a little scenario here. You have someone who has distance XT, near XT. Let's just say it's intermittent. Brackets around that. And that deviation is, well, that might be kind of generous. Let's go less, make it a little more realistic. 20 and 15. All right, so they don't have horrible exotropia, but they have intermittent deviation that's visible. And let's say that their refraction is plano. All right. So for them, you might over-minus RX them, give them -2, -150, maybe -1. Most kids can tolerate anything like that. Now, an adult probably wouldn't tolerate that. But what are you doing here? You're giving them minus correction, but their refraction is plano. What does that do? It stimulates, if I can spell, stimulates accommodation, right? They have to accommodate. And when they accommodate, they converge, all right? Another sample, what if they were, let's go to the hyperopic sample, all right? What if they weren't plano? What if they were +2? Well, that's going to be kind of hard to deal with because if you don't want to give them +2, there'll be more XT, right? So that's what I'm talking about. Don't do that. If you give them plano, Well, that's what they're walking around with anyway, so that's no net change. Someone like that, you'd have to give them something like -1. So now they're accommodating 3 diopters. That could help you potentially. And then the final thing is, what if they're myopic? All right, so what if they're myope? Well, here, let's just blank it out. If they're myope, they're a -2. What are you going to give them? Maybe I would RX them a -3 or -4. So again, the bottom line is you're causing extra accommodative effort to try and keep them straight. I do that occasionally. It's just a temporizing measure. You're not fixing anything, and eventually they're not going to be able to do it, right? I mean, a kid can do that, but other people can't. As you get older, they're going to be get uncomfortable from that, right? They're going to get uncomfortable because while a 6-year-old can accommodate that much, a 20-year-old can't do that, and certainly a 30-year-old can't. So sorry, I see what's happening. My iPad is trying to sync while we're doing our webinar, which is fun. All right, so yeah, over minusing is not a big fan. Basically, once they start to lose their control and they're noticing it a lot, I do their surgery. Now, why do we not do early surgery on a 2-year-old or 3-year-old for intermittent exotropia? It's because intermittent exotropia is a safe deviation, right? You don't get amblyopia. You don't really have much in the way of symptoms from it. But what if you do their surgery and they get overcorrected, which is not uncommon, especially early on after surgery. We usually have these early overcorrections. So now you have a 2-year-old who's overcorrected by 15 prism diopters of ET after BLR for exotropia. Now you have an amblyogenic condition. Now you're going to start suppressing one eye. Now you have to treat amblyopia. So I treat intermittent exotropia like a piece of fruit that's ripening. We know they're going to get worse. We know they're going to end up needing surgery 90-some% of the time. We're trying to time it to where they're in children, trying to time it where there's a balance between being too young and at risk for overcorrection and downsides, and being too old where kids are teasing them or they're having trouble in school. And so that normal range for me is between 3 and 5 ideally. And then it's totally different kettle of fish when you start talking about older kids and adults. For them, you just do it if it bothers them. All right, the bottom line. All right, let's go back to our live questions here. Question, what is the suggested approach for dealing with intermittent esotropia in a child? Well, intermittent esotropia, it really depends on if they have a refractive error or not, right? I mean, if they have a hyperopic refractive error, you give them their hyperopic correction. If they don't have a hyperopic refractive error, sometimes you can give bifocals, plano up top, but with a little bit of plus in the bottom, and that will buy you time because they're probably more symptomatic when things are up close. But you can test that with trial lenses. If someone has a 30 prism diopter intermittent esotropia, that's not a real and no significant refractive error. It's not a super common situation. And I would go slow with making a decision about any surgery. You can try prisms. You can operate on them, but I would be conservative about that, and I would make sure you followed them for a bit before doing that. You know, there are people with cyclic esotropia, and they eventually become more manifest over time. And even if they're cyclic, they tend to respond just as they normally would to surgery, even though they're straight part of the time. So they can have surgery if needed. Another question relative to ET. This is another live question. ET with accommodative spasmus. 8 diopters that you don't see with total refraction on glasses. All right. So people who have, this is similar. I mean, they're having intermittent esotropia and you're not finding a refractive error. It's kind of the same thing. You know, you can, if people have intermittent esotropia or spastic esotropia or accommodative esotropia without really any significant refractive error and it's variable, you can try to actropinize them for a while. I've had some luck with that. So they have no refractive error and they have this intermittent esotropia, which appears to be brought out by near activity, or they're blurred because they're actually walking around -2, even though they have a plano refractive error. You can put them on atropine for a couple of weeks. You might have to give them bifocals to get them by, but you can break this kind of accommodative spasm by giving them atropine for a little bit. All right, and I'm going to go back to our previously submitted questions. All right, next question here. All right, this is a question about dissociated horizontal deviation. So this is actually the same question. What do you do in cases of dissociated horizontal deviation? Yeah, so we definitely see dissociated horizontal deviation less commonly than we do dissociated vertical deviation, but the concept of the treatment is somewhat the same. Let me go to the whiteboard for this discussion because the management's a little bit different. I just lost my connection here. Here it comes. All right. All right. So if someone has DVD, all right, and we're seeing one eye or the other go up. Those are really weird eyes that I'm drawing, but you get the idea here. All right, so we're seeing one eye or the other just go up. Well, what do we normally do? Well, we're normally recessing the superior rectus on both sides. Even if it's asymmetric, we might do more on one side than the other. Occasionally you see a patient where they only have DVD on one eye and we just do a single superior rectus recession. All right, now we're talking about in the absence of inferior oblique overaction. All right, that's different. That's when we do anterior transpositions. So you can see unilateral DVD. And that's most commonly what you see with DHD. So what does that look like? You have someone, let's just say intermittently, one eye goes out, but the other eye never goes out, all right? It is purely one eye goes out when it's occluded, it comes back in when it's straight. Cover it, goes out, uncover it, comes back in, all right? It is dissociated from the other eye. So what do we do with this kind of situation? You recess this lateral, all right? Let me clean this up a bit. If I have someone with DVD, and it's most of the time horizontal, or I'm sorry, DHD. If I have someone with DHD, it is most of the time an XT DHD. That is what you see most commonly. And you can get somewhat of a prism diopter measurement on this, right? You can try to measure with prisms, but it's really hard to do. A lot of times, just like, let's just say it's going to be about a 20 deviation, not uncommon. What would I do for this? I am simply going to recess this lateral rectus, and I'm going to do a really large recession, just like I would do a really large recession for superior rectus for DVD. So I'm going to recess at 8 or 9. You can maybe even do more. You could probably do 10. But I want to do enough to cut down on that. All right, so that's pretty straightforward. You can do resections for both DVD and DHD. I guess I use those less commonly. My go-to is usually the recession for these. All right, and let's go back to another live question. Oh, iTunes is still trying to sync. Let me quit that again. Okay. This was a question about congenital XT and neurologic exams. I think we already touched on that. Nice diagnosis. Oh, already answered once. Okay, here's the open ones. What is your approach for large angle exotropia? Roughly 65 prism diopters. All right. Yeah, so large angle strabismus. Let's go back to the whiteboard. And just so you guys know, we're about less than 10 minutes left in our session today, and then we're going to wrap it up, okay? All right, so we have a large angle XT, 65 prism diopters. What are we going to do for that? All right, well, they'll usually tend to manifest on one eye, right? So they see it, the patient sees right eye XT, all right. And let's just say the motility is full. Might be trace amounts, but it should be pretty full. All right, so what do we need to do here? We got two eyes, right? This one's got a big XT, this one's kept on target. My approach to this, big recession over here. So we're gonna do a big R&R and resect or plicate. We'll talk about that for a second because I really like this. Resect or plicate, and I'll do large amounts. So how large is large? Usually for me, I might do, if I want to get about 45, I'll do about 8.5 recession, and I'll do 6 to 7 plication. All right, that'll give me in this ballpark 45 to 50. What do we have left over? We've got that leaves about 15 left over. So I'll go over to that lateral rectus and I'll do a large recession. So 8 millimeters there. That would be my approach to a 65 XT. They come back and they're undercorrected still. They're unlikely to be overcorrected by that. If they come back and they're undercorrected, I'll go back and I'll resect that or plicate that other muscle. You can have, of course, larger deviations. And if someone came in and they didn't have 65, they had 80 or 90 XT, I would do all four. I would do 1, 2, 3, 4, all at the same time. Okay. So it really just kind of depends on doing it that way, doing large amounts. All right, and I'm going to go back to our previously submitted questions here. How to operate on A and V patterns. All right, this is always a good question. I think I'm going to make this our last question. We'll come in right on an hour, and this one's going to take a couple minutes to discuss. Let's go to the whiteboard here. All right, so we're talking about A and Vs. Now, what you do for those is going to depend on if you have oblique muscle dysfunction. All right, so A patterns you tend to see with superior oblique overaction. V patterns you tend to see with inferior oblique overaction. in general. So if you have an A or V pattern with oblique muscle dysfunction, you ideally really need to operate on the obliques. So in this case, it's pretty easy. I just do inferior oblique recession or myectomy, and that's how I collapse the V pattern. This case, little more complicated because you're talking about the superior oblique and the possible induction of torsion if you do tenotomies. Now, a lot of these times you see these A pattern, it's going to be like an A pattern XT, and they don't have any fusion. They have this large manifest deviation. And if they don't have any fusion, you don't have to worry so much about post-operative torsion. So in that case, you just do SO tenotomies. If you have someone who's fusing or you're worried about torsion, then you can do posterior tenotomies. Now, why is that? It's because the anterior fibers are the torsional ones. So if we leave the front portion of the superior oblique tendon attached, then we can not induce any torsional changes. Now, the downside to that is it doesn't weaken the superior oblique quite as much as if you do a full disinsertion or full tenotomy. But the upside is it protects you from torsion. All right, so that's my approach in the presence of oblique muscle dysfunction. Now, what if you don't? What if you have, let's just say a V pattern XT? So they're like 40 XT, 30 XT, 15 XT. All right, so they've got this V pattern, but the motility looks normal, looks full. All right, well, what do you do with them? Well, there's no oblique muscle dysfunction. So in this case, we're going to look at this number right here, the 30 XT. So that's a bilateral lateral rectus recession for me of about 7 millimeters. And we're going to shift that. All right, so we talked about this mnemonic male, right? Medials to the apex, laterals to the empty space. If you're shifting the laterals for a V pattern, this is your V, you're shifting the laterals upward. So that's going to be with just say a 1/2 tenon width upshift. And if it was if you had a V pattern esotropia and you're working on the medials, then the medials would be shifted down. They'd be shifted towards the apex. That's where the A is. All right, so that's the approach to A and V patterns with pattern strabismus. All right, so we are at about an hour here. I think we will wrap it up, and we will continue these discussions in our next month or two as we continue going through these. I appreciate all the people who submitted really great questions in advance, and I appreciate those of you who have submitted some on the fly. And I hope it's okay that we kind of mix those two up. I like kind of going both ways with this a little bit. It's interesting to see what people come up with. But it is very helpful to have them in advance because I think that helps guide our discussion, and I can have some limited amount of material prepared in advance. All right. Thank you all, and we will join you again next time.